I would like to hand over to Dr. Sadiq concerning this presentation about JAK inhibitors.
Okay. Thank you very much. Appreciate the invitation. So I think that, we finally, after so many years of trying to treat alopecia areata, have found a treatment that has very consistent and excellent results with a relatively safe safety profile. The JAK inhibitors, a lot of this research comes from the work that's been done on other inflammatory and autoimmune processes that were talked about before, including atopic dermatitis and vitiligo. So when you activate the JAK-STAT pathway, which is a major pathway that's responsible for all of these so-called autoimmune type of processes, it leads to an increase, again, in inflammatory cytokines being released. The two major ones that have been targeted for JAK therapy include interleukin-15 and interferon gamma. So again, it moves into that, again, what we were just talking about, the etiology of hair loss and certain types of hair loss being most pronounced as a result of an inflammatory process. So here, as you can see, what happens that with the JAK receptors, when these cytokines bind, it leads to phosphorylation of both the JAK and STAT proteins. And this leads to, again, expression within the cell of these inflammatory mediators. So the goal of new therapeutic interventions has been to try to, again, prevent the JAK phosphorylation and STAT activation, which would, again, stop the activation of these inflammatory cascades within cells. So it's really all about, again, JAK inhibitors, again, with the JAK phosphorylation and STAT activation and being able to inhibit this JAK-STAT pathway. So here in this slide, again, it shows you, again, this interaction. The third mediator that's been looked at has been TYK2 as well. And also, it also is a cascade that when binds intracellularly can be responsible for, again, inflammatory processes. So interesting enough, the JAK1 and JAK2 pathways are the ones that are most involved in alopecia areata, whereas all three JAK, again, pathway mechanisms, as well as TYK2, play a greater role in atopic dermatitis and vitiligo. So here you can see there have been a number of clinical trials on the left of the two major, again, JAK inhibitors that have been studied by our research group and others include tofacitinib and ruxolitinib, but there are others that are now being tested, such as basitinib and the others that are listed here. They all seem to have a similar mechanism of action, and like, again, the drugs that are now used to treat psoriasis and atopic dermatitis, the question is which will give the best clearance in alopecia areata and which will give the longest, again, clearance pathways. So again, this is felt to be a T cell activation process. So you want to inhibit the T cell activation, which causes release of the inflammatory cytokines. And tofacitinib, which is the first, again, JAK inhibitor that was utilized, which inhibits both JAK1 and JAK3, can be, again, utilized in 5 to 10 milligrams PO twice a day. That's the dosage that showed the greatest efficacy in the clinical trials that we performed. Interestingly enough, it appears that children seem to respond better than adults. Significant results in terms of regrowth, of full amount of regrowth, even in alopecia totalis, again, occurred within the first 3 months. But also, there is some immune modulatory effect of these products, so there is a slight increased risk of infection, although I don't believe that it's really a major risk, and it's not anything that we really saw in any of our clinical trials. So here's a patient, as you can see here, that was treated with the oral, again, tofacitinib at baseline, month 9, month 12, month 20. These are remarkable results, similar to what we would see with oral corticosteroids that, again, give this degree of regrowth. But the interesting thing is that, again, the result, even when the drug was stopped, lasted for a prolonged period of time. Even though there was a relapse rate in the study, it was much less so when you use oral corticosteroids to treat alopecia areata / totalis. So topical, we've also done research with, again, topical JAK inhibitors as well, and there was some efficacy that we saw and some degree of hair regrowth, but nothing related to almost the 80 to 100% clearance that we saw with the oral products that are utilized. And we're still studying now another of the new generation JAK inhibitors topically to see whether it's efficacious. However, in general, our experience in studying several of these agents is that the oral agents respond a lot better when systemically rather than the topical agents. And here you can see one of the topical treatment programs that was utilized in the study, which showed some degree of regrowth, but again, not the same amount of regrowth and the same consistency of regrowth that we see with the oral systemically ingest JAK inhibitors. Here's the next generation ruxolitinib as well. It's a 1 and 2 inhibitor as well, and 20 milligrams twice a day. Notice that the half-life of these products is about 12 hours. That's why most of them need to be, again, ingested twice a day rather than once a day. But interestingly, again, you can see that the results occur very quickly within a period of just several weeks. And again, if you stop it, you can see cessation and recurrence of the hair loss. But I've noticed in a number of patients that we've followed in our studies that there is some prolongation of where you continue to see hair regrowth. In this study that was published now 2 years ago, looking at ruxolitinib from their initial studies, 10 milligrams twice a day for 7 months with excellent regrowth. So in general, like all other alopecia areata interventions, you do need to keep patients on the drug. And we're encouraging the companies that produce these JAK inhibitors, because of the slight, again, infectious or immunosuppressive ability of these drugs, to see whether alternate day dosing or, again, dosing once or twice a week may be as effective, that may be more easily, again, utilized by these patients. In this study using topical ruxolitinib, again, it was just limited efficacy, and that's been our results with all of these agents. They're just not as good as the oral agents, and unless for some reason a patient doesn't want to take the slight risk of infection occurring with the systemic agents, I really recommend the systemic agents for all of our patients. And here's one of the new products again, as you can see here, with excellent results in their, again, phase 3 trials. This is one that we studied in our research group. The active site for this CTP 543 drug was, again, similarly in the cytoplasm, again, cutting down on the T cell mediated inflammatory cascade. Here's a study performed again this year with phase 2 study looking at CTP 543, a new generation selective Janus kinase inhibitor in moderate to severe alopecia areata with excellent results. And this has been my experience with all of the oral agents. They tend to do extremely well, and I haven't really found a favorite yet, although more long-term studies, really need to be carried out to see. Yes?
Dr. Sadiq, the previous one, is it JAK1 and JAK3 inhibitor also or not?
JAK1 and JAK3, yes.
Also, okay, thanks.
So here's one of the new generation 1 and 2 inhibitors, baricitinib. Again, as you can see here, this came out in the New England Journal of Medicine, which shows you how important the consideration of this as a new immune modulatory treatment is, because again, these are very quite safe drugs, and they really dramatically improve alopecia areata, which can have systemic emotional effect upon individuals that are affected by this treatment. And here, as you can see, before and after, again, after 36 weeks, using, again, the baricitinib, again, with excellent regrowth. It's interestingly that with these drugs, when the hair begins to regrow, it begins to regrow uniformly throughout the entire scalp. So it's not just some patches come in and then others improve. There is more of a global improvement with these types of agents. And again, there are several, again, new products that are being looked at now. There's one that has the other mechanism of TYK2 and JAK1, brepocitinib as well, and ruxolitinib, which is a JAK3 inhibitor. So again, with excellent results, looking at these twice a day, rapid onset, and improved safety profile. So the question that's being looked at now, as you can see in this study, is whether a combination of using either 2 JAK inhibitors or a JAK inhibitor and a TYK2 inhibitor may have more efficacious results, or in treatment of those individuals that are refractory to one. And here, looking at one of the new generation products, rituximab, again, as you can see here, 200 milligrams daily, and then moving into 24 weeks to 50 milligrams, excellent results, again, including alopecia totalis and universalis. Interestingly, most of the drugs other than this, the rituximab, have been used to treat alopecia areata, moderate to severe, or alopecia totalis. but this is one of the first drugs that was looked at for both totalis and universalis as well. And you can see here in this phase 2A randomized placebo, the utilization of these two products, two inhibitors, the oral Janus kinase inhibitors, ritlecitinib and brepocitinib, again, showed excellent results in terms of regrowth. So the safety profile, like all of these immune modulatory drugs that are studied and are utilized, the major side effect, which is very rare, are upper respiratory tract infections. There's no unusual infections that one might consider to be an immunocompromised host, and the others are really uncommon, the others that I've listed here. The major issue with all of these drugs that we test that have some immunomodulatory effect are upper respiratory tract infections, which are self-limited. But there is some degree of immunosuppression, so we have to tell our patients that there theoretically is an increased cancer risk, but I've not read of any large trials showing epidemiology that of increased risk of actual cancer away from the normal population. So the question is, does using one product that doesn't work, does that mean that other, again, JAK inhibitors will not work as well? And this is something that's still being looked at. You can see in this study, there was complete regrowth after changing to a different ruxolitinib JAK inhibitor. The SALT is, again, a measurement system we use to determine the degree of alopecia and alopecia areata and alopecia totalis. So if you don't have efficacy with one, and these studies are now ongoing, you can try a different drug that has a different, again, suppression of JAK1, 2, 3, or the TYK2, again, molecule. So here's the current treatment algorithm that we utilize. We usually utilize just one JAK inhibitor to start. I discourage my patients from thinking of using a topical agent, although some don't want anything that has potential immunosuppression. And then we usually treat them for up to 6 months to see whether or not there's efficacious, although 20 weeks was a timeline break-off in most of the studies that we're performing. And then if they don't respond, you can switch them to, again, a second agent. If there's partial response, you can add a second agent, and hopefully there'll be synergism between the two agents. So in conclusion, again, I think the JAK inhibitors really are play a miraculous role in the treatment of, again, T-cell mediated alopecia areata, totalis, and universalis, both in the pediatric population and adults, and we've done studies looking at both populations. I believe that there certainly needs to be some sort of maintenance therapy, although I think it's important with extension studies for the companies to look at, again, more intermittent dosing for, again, maintenance type of programs. And we really don't know the optimal loading doses or even the optimal duration of maintenance programs that should be utilized using, again, these JAK inhibitors. The long-term safety, somewhat of a concern. I'm less concerned. We've been studying these drugs now for about 6 or 7 years in our research group. I've not heard or heard of any cancer type risk, but again, it is somewhat of an immunosuppressive agent acting on an immunosuppressive anti-inflammatory pathway. So we still need to look at it in further long-term studies. And again, this can be utilized by itself. That's all we really need in the majority of individuals, but you can use other immunomodulatory approaches. If someone has a partial response, we like going to add PRP. That's our #1 intervention in an incomplete. If we switch from one JAK inhibitor to another and they still don't have response, and I usually add PRP to see if there's any additive synergism in that setting. Thank you very much for the opportunity to present this new information.
Fascinating. My God, so many new options. Dr. Buana, do you have question for Dr. Sadiq?
Thank you, Neil, for this very impressive result and very nice protocol. I have one question before the other question of the audience. Do you think that we actually can prescribe JAK safely during the COVID pandemic?
That's an intriguing question without, a definitive answer. Personally, I think that so many patients here in the U.S. and globally, and particularly here in the U.S., are on these JAK inhibitors for, again, alopecia areata, alopecia totalis, and there are now studies looking at them for treatment of atopic dermatitis, and there haven't been any signs of increasing immunosuppression. One other side effect that we did observe, which I should have mentioned, that a small subset of patients can develop an anemia as well. It's a normocytic normochromic anemia. So we do monitor intermittently, again, CBCs on these patients as well. But in general, I would say if you can wait till someone becomes COVID negative serologically and clinically, that's probably the prudent thing to do with anything that has any potential immunosuppression. However, I don't really think that it's a problem in that population. And in the US right now, we're going through a new phase of this right now. And, we screen all of our patients in these studies for COVID, and we wouldn't enter them, obviously, if they were positive. But I don't think there is, an increased risk, although I would stay on the conservative side and wait till they become COVID serologically negative.
Thank you.
Dr. Sadit, you mentioned, obviously, there is a question mark concerning the long-term safety. You mentioned about long-term safety. How long does it mean, long-term safety?
Well, I think these products have now been under investigation now close to 5 years. So that's as much information that we have, from the earliest, tofacitinib, which was the first one that was brought to market. So I think they're relatively safe. But with anything that has any immune modulatory alteration in our systems, that's something that we need to bring forth to our patients, that it is that type of drug. But there have not been any studies showing an increased cancer risk or risk of opportunistic infection using these drugs.
Okay. So among all those options, because you mentioned a lot of molecule in development, which JAK inhibitor is best for alopecia? Because doctor needs to understand by which one they have to start with. Obviously, it has to be registered.
Tofacitinib is the one that we use mostly in our practice now. It has the longest history.
Okay. And how long does it take for JAK inhibitor to work on alopecia?
It works pretty quickly. We've seen some results even in a month, which has shocked me. But a few months is what we tell patients. I'm sitting here with a couple of members of my staff and research group listening to this. But we've been shocked, in terms of how fast they work. And they can work just within a period of weeks in susceptible responders.
There is a question from Dr. Bagishi from Iran. You already talked about this, the difference between topical and systemic. Is topical tofacitinib effective?
I've not found it, again, particularly effective, any of the topical variants. We're still testing a couple right now. Again, this is still an evolving area space, which because of the pronounced efficacy, also in vitiligo, it appears to be a game changer as well. So almost every company is now coming up with some variant of this, either working through the JAK 1, 2, 3 pathway or through the TYK2 pathway. So, but the topical agents have not been effective in my hands. I've tried some topicals for vitiligo as well and not found them to be effective in that setting.
Okay. To the rest of the faculty, if you have a question for Neil, please feel free. I have another question from the, from Dr. Abdi, still from Iran. Please tell us about JAK inhibitor contraindication and or complications.
Well, again, as I mentioned, the major theoretic issue is immunosuppression. Anemia is something that has been reported. I would not use these products in someone that's attempting pregnancy. I think that's something that I would not utilize at this time.
Okay. Let me.
The other relative contraindication is very high cholesterol. I don't think personally that's a major problem, but it's listed in when we do our studies.
Okay.
And TB, of course, is something with all of these agents you want to be sure. And we talked about this at our Professors Congress this weekend. Many people will have a prolonged positive skin test for TB. That doesn't mean they have active TB, and you can selectively look at their results of their PPDs and other tests now to determine whether, again, this is old latent TB that has no chance of being reactivated. So although we do, again, PPDs or tuberculin tests in all these patients, if a lot of people are PPD positive, we then do more sophisticated testing to see whether they're at that risk for reactivation. And an
Okay.
X-ray can be done as well if it's positive, but there are a lot of people that have sort of prolonged positive PPDs without any potential for active reactivation of TB.
Okay. There is a question from Dr. Mokbel from Saudi Arabia. Can you tell us about the use of JAK in children's patients?
Yeah, there are studies. I think they are very safe in children, and we've done one study and we're getting ready to do another study on utilization of these products in children. I think they're quite safe and they're game changers. And we know that, again, there is a high incidence of alopecia, T-cell mediated alopecia syndromes in the pediatric population as well. So I believe that they are safe in this population.
Okay. A question from Dr. Perez Meza from Mexico. He congratulates you for your presentation. He said, Aclaris did an AA study a few years ago, but it was canceled. Do you know any why this study was discontinued?
I think that had more to do with internal issues within the company rather than any safety or efficacy concerns.
Okay. Anyone from the faculty or Dr. Buena, if you have a question, please feel free to ask.
Yes, Dominique. Could
yeah.
I ask
please,
Neil
please,
a question?
Please.
Thank you for your presentation, Neil. What are your thoughts on JAK inhibitors and thromboembolism?
Yeah, I mean, there's been some suggestion of the potential of increased thromboembolic phenomena, but I don't think that's been shown to be the case in any of the studies of these products that are out there now, other than what one sees in the normal population. So to date, although we're watching it on the outside, I don't think there's an increased role of hypercoagulable states. Do you have a different opinion?
Thank you. No, I share your view. Actually, we've never had we use JAK inhibitors, and thankfully we've never had any cases of thromboembolism. But I'm aware that a number of patients are aware of that risk, and the question sometimes arises.
If you look at the studies, though, the risk versus a normal population really is not significantly increased.
Okay, a question from Dr. Austria from the Philippines. Will there be interaction with JAK inhibitor and other oral medication like oral isotretinoin, antibacterial, antifungal, antivirals?
I don't believe that there's any contraindication for any of those drugs. They're not on the list of contraindicated drugs that we cross off that patients cannot be on during our studies. So the answer is no.
Okay. A question from Dr. Shah from India. Is family history of cancer by itself a contraindicated?
Not at all, not if there's a family history. If the patient is immunocompromised with cancer or something like that, then it becomes an individual decision based upon the patient's doctor and ourselves, but not the family members.
Okay. I think that's about it, unless anyone from the faculty has a question to Dr. Sadiq.
Just a quick comment,
Sure.
Neil, congratulations, it has been a fantastic talk. Do you recommend any specific advice regarding the vaccinations previous to receive a JAK inhibitor?
I would not start a JAK inhibitor within a few weeks of having, again, COVID or other vaccinations in general. Anything that can put out of line or already is, a potentially immune-changing intervention, there's no need to start. I would wait several weeks after any vaccination.
Thank you so much.
Not months, but just weeks.
Dr. Buena, do you have
Yeah.
another question for Dr. Sadiq?
No question, and congratulations for a nice presentation.
Thank you very much.